Hi, this is Andrea Kane, and I'm here with you for HIT 120 Pharmacology. We are now on week 5, and we are going to be discussing cardiovascular system drugs this week. And I need to warn you, this is a long PowerPoint. I apologize, but there's so much information for us to go through together. If you take a look at the syllabus, you'll notice we're focusing on textbook chapters 11 through 15. So that's antihypertensive drugs through lipid-lowering drugs. I am not going to lecture about anything with pathophysiology. It's not included in these slides. It will not be included on your quiz. But I would encourage you to go out there and take a look at it. You may find some additional information that's helpful to you to understand some of the cardiovascular conditions we're going to talk about today. If you are looking at your syllabus as well, you will see that we are focusing on unit objectives 9.3.1 through 9.3.2 and 9.4.1 through 9.4.2. So those are the ones that we'll be focusing on really over the next several weeks as we go through body systems. You are welcome to pull out your book and take a look at it as we go through this, but it's not necessary. I've tried to keep everything here in the PowerPoint so that you have it to study from start to finish. Okay, so our contents. We're going to do a brief cardiovascular review. We'll talk about antihypertensive drugs, ischemic and congestive heart disease drugs, antiarrhythmic drugs, drugs that affect the blood, and lipid-lowering drugs. So we have plenty to cover. All right, one of the first things I wanted to do is when we talk about cardiovascular systems, talk about what are the most common ones that are treated and the types of hypertensive drugs that may be indicated. Because we're going to be talking and spending quite a bit of our time on hypertensive drugs. And you can see there are some very serious conditions that are involved with that. So we will go through those, but I bring this to your attention simply to make you aware that there's a wide variety here. And as you can see, many of the hypertensive drugs are used for multiple conditions. All right, so hypertension. Why talk about hypertension? What is hypertension? Is it important? All those types of things. Well, let's talk about it. There are different categories, and you can see here that it gives you systolic and diastolic. Your blood pressure is a number over a number. That's your systolic over your diastolic. You can see here normal is 120 over 80, less than both of those. Elevated is above that. High blood pressure or hypertension stage 1 is above that. High blood pressure, hypertension stage 2 is even higher. And then hypertensive crisis. This is the kind of thing that you want to head straight to an emergency room for because you're going to need some significant treatment. It's very, very, very serious. Hypertension affects your whole body. It has been shown that hypertension is implicated definitely directly in terms of stroke, but it can exacerbate depression and anxiety. It can cause loss of vision. Definitely it influences and significantly advances heart disease and kidney disease. There can also be bone loss or sexual problems. I thought this was interesting. The CDC had this up on their website where it shows the prevalence of hypertension. Now, this is 2017, so it's approximately 3.5 years old, I would say. But this shows you U.S. adults ages 20 or older where the prevalence is. If you look at Iowa, you can see we're not the lowest. We're not the highest by any rate, but we're definitely not the lowest. So there are a lot of people across the country that are struggling with hypertension. The risk factors for hypertension include age and ethnicity, smoking, high salt intake, health problems, inactive lifestyle, alcohol, high stress level, and obesity. Some drugs that may raise blood pressure include NSAIDs, non-steroidal anti-inflammatory drugs, allergy and cold medicines, corticosteroids, and cyclosporine. So it's just something to bring to your attention and awareness. We need to talk about MAP. That is mean arterial pressure. Sorry, I wanted to go ahead and flip to the next slide. But mean arterial pressure is your diastolic blood pressure plus 1/3 of your pulse pressure. That is used heavily in healthcare. Your MAP, normal MAP, should be around 95 mmHg. MAPs greater than 65 keep your organs perfused, meaning that they keep the oxygenated blood flowing to your kidneys, heart, and brain. When your MAP, when your MAP falls less than that, it can lead to shock. When it gets way too high, it can lead to stroke. So you can see why you want to keep it in a normal range. Both low and high MAP can lead to organ injury. So it's really important that your MAP is managed well, is what I want to communicate. So what do you need to know on this slide? You need to know what MAP is in terms of blood pressure, that it is normal at 95, that you need to keep it 65 or greater for organ perfusion of the kidneys, heart, and brain. Please be sure to know that low MAP leads to shock and high MAP leads to stroke. I'm going to tell you that again. Low and high, you need to know that because it will probably be on your quiz, hint, hint, hint. But know that both low and high MAP can lead to organ injury. MAP is determined by your cardiac output times your peripheral vascular resistance. So what does this mean? It means that if you decrease your cardiac output or you decrease your peripheral resistance, your peripheral vascular resistance, you lower blood pressure. Make sure you understand this. So your MAP, your mean arterial pressure, is cardiac output times peripheral vascular resistance. If you decrease one or the other, if you decrease cardiac output or you decrease peripheral vascular resistance, you will lower blood pressure. Please make sure you know this. The opposite is also true. If you have high blood pressure, then you either have increased cardiac output or increased peripheral resistance as the cause. So make sure that's clear in your mind. Low cardiac output or low peripheral vascular resistance equals low blood pressure. High cardiac output or high peripheral vascular resistance equals high blood pressure. So what is cardiac output? Things that increase it are increased heart rate, increased contractility of the heart, how much it's contracting, and increased sodium with water retention. Those all increase cardiac output. So think about the opposite. Things that will decrease cardiac output include a slower heart rate, decreased contractility of the heart, and decreased sodium with less water retention. So again, make sure you have that in your mind. Things that increase peripheral vascular resistance are vasoconstrictors. Anything that is a vasoconstrictor is going to increase peripheral resistance. Because think about it, if you're constricting something, you're squeezing it. You're causing that peripheral resistance. If you dilate it, you're decreasing that peripheral resistance because you're making it bigger so more can flow through it. So things that increase peripheral resistance are vasoconstrictors. Things that decrease peripheral vascular resistance are vasodilators. So let's talk about things that influence blood pressure. Diuretics can decrease blood volume. Drugs that interfere with the renin-angiotensin system, which is your salt-water balance, and drugs that can decrease cardiac output or peripheral resistance, such as vasodilators or sympathetic nerve depressants, like alpha and beta blockers and clonidine. Drugs, things that can also influence your blood pressure would be vasoconstrictors, okay? But the things that you want to do to decrease that blood pressure are diuretics, drugs that interfere with that renin-angiotensin system of saltwater balance, because of course you want to decrease sodium and lessen water retention. You want to decrease cardiac output or peripheral resistance through vasodilators or sympathetic nerve system depressants, which are also known as alpha and beta blockers, and clonidine. All right, so very important slide. Examples of diuretics are thiazides, loop diuretics, and potassium-sparing diuretics. Make sure you know those three, that you can recognize them. That if you see the word thiazide, you think diuretic. If you see loop, you think diuretic. If you see potassium-sparing, you think diuretic. Examples of renin-angiotensin system interference drugs. These are ACE inhibitors, ARBs, aldosterone antagonists, and direct renin inhibitors, and we'll talk more about that. But again, anything that inhibits or interferes with renin-angiotensin system, which is salt and water, is something that will help. Drugs that decrease peripheral vascular resistance or cardiac output are those vasodilators and sympathetic nerve depressants, alpha beta blockers, and clonidine. Examples of direct vasodilators include calcium channel blockers and nitrates. Examples of that sympathetic nerve depressant, again, are alpha and beta blockers and clonidine. So, okay, make sure you know that. The things that are going to be influencing lowering that blood pressure are diuretics, renin-angiotensin system interference drugs, drugs that decrease peripheral vascular resistance or cardiac output, which are direct vasodilators, sympathetic nerve system depressants. All right, quick quiz. What does mean arterial pressure equal? So what does MAP equal? Those two things. How can you lower blood pressure? What two things lower blood pressure? True or false, a beta blocker, like Lopressor, is an example of a sympathetic nerve depressant which can lower blood pressure. I think you can get all three of these from the last slides we just went through. And I will tell you that some of these quick quiz questions are actually on your quiz. Hint, hint, hint. All right, so let's go into diuretics and focus on those. Diuretics increase urine flow. They act in the kidneys and they lower blood pressure. They're often used in combination with other antihypertensive drugs. You will see as we go through talking through all these antihypertensive drugs, there are multiple used at the same time. Typically, they're attacking the hypertension from different angles, so it's not uncommon for patients to have two or three antihypertensive drugs at the same time. The three major types of diuretics are thiazides, loop diuretics, and potassium-sparing diuretics. Thiazides and loop diuretics can cause a loss of potassium and dehydration. Okay, so thiazides and loop diuretics can cause a loss of potassium. Potassium-sparing diuretics do not cause a loss of potassium, but if they are overused, they can cause an excess of potassium, which is known as hyperkalemia. Thiazides and loop diuretics can increase the toxicity of drugs that cause damage to the ear and the kidney. That's their side effects. Loop diuretics are also used to reduce pulmonary edema, usually due to congestive heart failure, and hypertension that's caused by renal insufficiency. That's where the kidneys aren't functioning optimally. Loop diuretics are the most potent type of diuretic. Make sure you know that. Loop diuretics are the most potent out of all three. So let's talk about thiazide diuretics. Break it down, see what's under there. This just lists the drug, the indications, possible side effects, some potential interactions, some precautions and contraindications. It's just here because I thought you'd be interested in it. But what I really want you to know off this slide is the most common thiazide diuretic prescribed is HCTZ. HCTZ. Hydrochlorothiazide. Hydrochlorothiazide. thiazide, HCTZ. That is the most common thiazide diuretic that is used. You need to know that. Loop diuretics. The most common ones you are going to see or hear about are Lasix and Bumix. Okay? And that's really what I want you to get out of loop diuretics. Lasix, Bumix. Those are the most common brand names. Potassium-sparing diuretics. And this just shows you what those are, some side effects of those. And it reminds you to avoid high potassium foods. This is one of those where it's important to educate patients that eating high potassium foods when you're taking a potassium-sparing diuretic can cause you to have too much potassium, hyperkalemia. And some high potassium foods include bananas, potatoes, spinach, broccoli, nuts, prunes, tomatoes, oranges, and peaches. The brand names for potassium-sparing diuretics that I want you to be familiar with because they are very common are Aldactone and Inspira. Aldactone and Inspira. Interestingly enough, there are a lot of drug interactions when it comes to diuretics, specifically when you're talking about the elderly. And the next 3 slides are about that to remind you that if you're using a diuretic, make sure that you are careful about what else you prescribe with the patient. Not that we in HIT prescribe for patients, but it's a good idea to know that diuretics, especially in the elderly, can have a lot of drug interactions. And this is just to give you an idea of some of these. Okay, so quick quiz questions. What are the 3 types of diuretics? Which diuretic type is the most potent? And this is a fill in the blank kind of one where I wanted you to be familiar with the brand names for each type of diuretic. Angiotensin and aldosterone. These are really, really important to know. Angiotensin is a protein hormone in blood that causes vasoconstriction and promotes aldosterone secretion from the adrenal cortex in the kidney to promote sodium retention by the kidneys. Angiotensin raises blood pressure. Okay? Angiotensin raises blood pressure. You need to know this. Angiotensin raises blood pressure. Angiotensin production is stimulated by an enzyme called renin. Okay? Angiotensin production is stimulated by an enzyme called renin. Angiotensin raises blood pressure because it causes vasoconstriction and it promotes aldosterone secretion. What is aldosterone? Aldosterone is a steroid hormone that regulates salt and water in the body, specifically the kidneys, salivary glands, sweat glands, and colon. When you have too much aldosterone, your potassium decreases, your sodium increases, and your blood pressure goes up, and you have edema. When you have a deficiency of aldosterone, your potassium increases, your sodium decreases, and you have lower blood pressure and decreased edema. Can you see why this is important? So let's go back. Angiotensin production is stimulated by an enzyme called renin. Angiotensin causes vasoconstriction and promotes aldosterone secretion. Aldosterone secretion in excess causes your potassium to go down, your sodium to go up, your blood pressure to go up, and you to have edema. That's the relationship that you really need to know. So now that you know that, now that you know about angiotensin, aldosterone, and renin, what does that mean when we're talking antihypertensive drugs? Well, the first one we're going to talk about is called an ACE inhibitor. an angiotensin converting enzyme inhibitor. So it's exactly what it says. It's inhibiting angiotensin. It's blocking the synthesis of that, which decreases the level of circulating vasoconstrictor, which reduces aldosterone secretion, which reduces water retention and edema and reduces blood pressure. Some examples to know are captopril and enalapril. Don't know why I can't spit that out, but enalapril. So you've got ACE inhibitors, where you're inhibiting something that has to do with angiotensin. That's actually the synthesis of it. Then you have ARBs, angiotensin receptor blockers. Exactly what it's saying. It's interfering with that binding of angiotensin with its receptor. It's blocking angiotensin. This decreases the level of circulating vasoconstrictor. And the two types you need to know are losartan and valsartan. Those are the most common ones used. Another antihypertensive, aldosterone receptor antagonist. Exactly what it sounds like. It's blocking the action of aldosterone when it comes to the receptor. This increases urinary excretion of sodium. Unfortunately, it also has increased hormonal side effects. But this is a very common one. And you need to know spironolactone or aldactone. Spironolactone or aldactone. Okay? Next one, selective aldosterone receptor antagonist. So if you notice the last one, it was ARA. This next one is SARA. This is selective. And the difference between the two, they do the exact same thing. See, this one blocks the action of the aldosterone receptor. This one does too. But this one does it without increasing the hormonal side effects. And what you need to know here is that the ones you need to know are eplerenone or Inspra. Okay, so ARA and SARA are identical in blocking the action of the aldosterone receptor. That increases urinary excretion of sodium, but ARA has an increased hormonal side effect. SARA has a decreased. Then you have a direct renin inhibitor, and this is called a DRI. Remember, renin is the enzyme that produces angiotensin, so this is going right at it, stopping it before it even gets to angiotensin, which causes vasodilation. And aliskiren is the new drug that you need to know. So some quick quiz questions. What are the 3 items that are involved in influencing blood pressure? We talked about those, and I give you the third one, which is renin. If potassium increases, what else happens? You need to give me 3. If potassium increases, what else happens? Give me 3. Then the last is spell a drug name for each type of diuretic. And I tell you ACE, ARB, ARA, or SARA. And I even give you the first letter. Another type of antihypertensive is a calcium channel blocker. Calcium channel blockers inhibit the entry of calcium into cells. Just exactly what they sound like. They block calcium from getting into cells. When the entry of calcium into smooth muscle cells is inhibited, the vessels will dilate. Okay, so think about that. If you prevent calcium from getting into those smooth muscle cells, the vessels will dilate. That's why it helps with hypertension. You want to keep that calcium out. Some examples to know are amlodipine or Norvasc, diltiazem or Cardizem, nifedipine or Procardia. These are all very common calcium channel blockers used as antihypertensives. All right, next one, nitrates. Nitrates dilate blood vessels and reduce cardiac preload. Their mechanism is not well understood. It's thought to be related to nitric oxide, but here's the thing. Nitrates are used for hypertension, but they're also used for angina and acute coronary spasm. Please know this. Nitrates dilate blood vessels. They are used for hypertension, angina, and acute coronary spasm. And the most common form of nitrate that is used is nitroglycerin. Typically it's under the tongue, but it can also be given via patch. But you really need to know that it's used for hypertension, angina, and acute coronary spasm, and it's the version that they give is nitroglycerin. It dilates blood vessels. Some other direct vasodilators that are used as antihypertensives include drugs like hydralazine and minoxidil. Hydralazine and minoxidil relax arterioles. Not really sure why or how, but they do. Now they have some pretty ugly side effects, so they're often prescribed with additional drugs that counteract those. Phenoldiazepam is a dopamine agonist that is often used for acute treatment of severe hypertension. That hypertensive crisis we talked about at the beginning, because it dilates renal and mesenteric vascular beds. All right, another type of antihypertensive includes alpha and beta blockers. Okay, so let's talk about this. Why are we talking about alpha and beta blockers? Well, we talked about sympathetic nerve system. Sympathetic nerve system blood vessels are under alpha and beta receptor control. Alpha antagonists cause vasodilation. Beta antagonists decrease heart rate, cardiac output, and renin release. They decrease all three of those. The ones I want you to know are all beta antagonists. These are the ones that are used most often. Labetalol, which remember is often used with hypertension in pregnancy. Metoprolol, which is low pressor, and propranolol, Inderal. These three drugs are very frequently used with hypertension. Again, labetalol is for pregnancy-induced hypertension. But what you need to remember is about alpha and beta blockers. When you're blocking those receptors, you're opening those blood vessels to cause vasodilation, decreasing heart rate, decreasing cardiac output, and decreasing renin release. Clonidine is an alpha-2 agonist, and it's an odd one. Clonidine does not act like most alpha agonists, because most alpha agonists cause vasoconstriction, but not in clonidine. So for some reason, it works in the brain to change some of the sympathetic nerve impulses and relaxes blood vessels. Interestingly enough, it's also used for ADHD, menopausal flushing, diarrhea, drug withdrawal, and cancer pain. But what I want you to know about this is clonidine is used for hypertension. It is an alpha agonist, but it's an odd one because it causes vasoconstriction, and almost all other alpha agonists cause vasoconstriction. Not this one, though. Clonidine causes vasodilation because it works on relaxing those blood vessels by changing some of those chemical messages. So know that clonidine is an antihypertensive, even though it's an alpha agonist. It's very unique in how it acts. All other alpha agonists cause vasoconstriction, but not clonidine. All right, quick quiz. If calcium is inhibited from entering smooth muscle cells, then these vessels will do what? Will they constrict or will they dilate? Nitroglycerin is used for hypertension in which two other conditions? And A should be acute coronary spasm. Sorry about that. Spell a brand drug name for each type of diuretic. So if you have a calcium, I'm sorry, it should say for each type of antihypertensive. They're not necessarily diuretics. My apologies there. I'll have to fix that. So spell a brand name drug for a calcium channel blocker, alpha antagonist, and beta antagonist. Ischemic heart disease. Ischemic heart disease is not enough oxygen to meet the heart's need. It is caused by coronary artery disease, or CAD. It limits the blood flow to the heart. So let me say that again. Ischemic heart disease means there's not enough oxygen to meet the heart's need. It is caused by coronary artery disease, and it limits the blood flow to the heart. Beta blockers reduce myocardial oxygen demand. Calcium channel blockers reduce vascular resistance and myocardial contractility. Nitrates produce venous dilation. Antiplatelet drugs prevent thrombus formation, and lipid-lowering drugs reduce the risk of AMI. What I want you to know off this slide so far is ischemic heart disease. And then I need you to know that ischemic heart disease is treated by beta blockers, calcium channel blockers, nitrates, antiplatelet drugs, and lipid-lowering drugs. You don't necessarily need to know what they all do. I just want you to know what is ischemic heart disease and what are the types of drugs that are used to treat it. The beta blockers, calcium channel blockers, nitrates, antiplatelet drugs, and lipid-lowering drugs. There are 3 stages to ischemic heart disease, and we'll see that on the next slide. It starts out with ischemic heart disease, which is CAD, remember, coronary artery disease. Then it moves into unstable angina, and then it progresses to AMI, which is acute myocardial infarction, also known as a heart attack. All right, so ischemic heart disease is caused by coronary artery disease. Yes, the plaque builds up in the artery. Then you have it advancing to angina, whether that's stable or unstable angina, where it's harder for the blood to get through the artery. Then that can develop into an acute myocardial infarction, an AMI, or a heart attack where the plaque cracks and a blood clot blocks the artery. And this is on causes and risk factors for coronary artery disease. And I'd encourage you to become familiar with that. It's not on the quiz, but it's good to know. Congestive heart disease or congestive heart failure. This is not the same as ischemic heart disease. Make sure you understand the difference between these two. They're 2 totally different things caused by 2 totally different situations. And they're treated very differently. Okay, so set aside everything about ischemic heart disease and coronary artery disease. Put that all aside. We're now on to congestive heart disease or congestive heart failure. This is where the heart can no longer pump enough blood to meet the demands of the body. The treatment for CHF or congestive heart failure, congestive heart disease, is managing symptoms. Please make sure you understand that. It's managing symptoms. Those symptoms are decreasing cardiac workload, controlling excess fluid, and enhancing myocardial contractility. Please make sure these first 2 bullets you have fully memorized. Then the next ones, what I want you to know. How do you decrease cardiac workload? You use beta blockers, ACE inhibitors, and or vasodilators. Because again, you want the heart to work better. You control excess fluid. So you're using those diuretics and you're encouraging the patient to decrease their dietary intake of sodium. And then you enhance myocardial contractility with cardiac glycosides. This is digitalis, digoxin, digitoxin. But you have to worry about a side effect of cardiac arrhythmia when you give those. So enhancing myocardial contractility is cardiac glycosides or sympathomimetics, which include dobutamine, beta agonist, or dopamine. There's also phosphodiesterase inhibitors. We'll talk briefly about those, and ranelazine, which reduces cardiac or calcium overload. But what's in bold here is what I want you to make sure that you are very familiar with. This next visual is the two types of congestive heart disease or congestive heart failure. If it is left heart, it is diastolic. You have stiff and thick chambers, the heart can't fill. If it is right-sided heart disease, it's systolic. You have stretched and thin chambers, the heart can't pump. These are the two types of heart failure, okay, that you need to understand. Arrhythmias. Arrhythmias are disturbances of the normal rhythm of the heart. They occur when electrical conduction systems malfunction. What do you mean by malfunction? Well, it's a change in heart rate, rhythm, impulse generation, or conduction of electrical signals through the heart muscle. There are typically, let me stop here. Typically, drug approaches are used first. If a drug approach will not work or is contraindicated, then non-drug approaches, which are surgical, are done. Non-drug approaches, i.e. surgical, include pacemakers, implantable defibrillators, and or ablation of an aberrant conduction pathway. But again, those non-drug approaches are usually last resort. They're usually after they've tried to use a drug approach or to do a drug version of cardioversion. If that doesn't work or if it's contraindicated, meaning that the drugs that they would use to do that are too much for the person, then they will do the non-drug approach. But non-drug approaches are not usually the first choice, just so you know. All right, so when we're talking about arrhythmias, when we want to think about drug options, the quickest and easiest way is to think sodium, potassium, and calcium. And I'll come back to that explanation, but keep that in mind. Okay, this is a visual for you of irregular heart rhythms on the left. There's the tachycardia at the top, bradycardia. And tachycardia, remember from medical terminology, it means your heart rate is going too fast. Bradycardia is your heart rate is going too slow. Extrasystole, you have an extra beat in there. Atrial fibrillation, atrial flutter, ventricular flutter, those are all types where your valves are going inappropriately and it's causing your heart to go faster or differently than it should. You can see on the right at the top, they give you the normal heart rhythm, so you can compare that. And then at the bottom, it should say myocardial infarction. It should be MYO, myocardial infarction. And that is the stages of a heart attack. So you can see 1, 2, 3, 4, how that affects your heart rhythm. 7 signs of arrhythmia include tachycardia, bradycardia, fainting, confusion, profuse sweating, shortness of breath, and dizziness. And remember, tachycardia means your heart rate is too fast. Bradycardia means it's too slow. All right, let's talk about antiarrhythmic drugs. There are 4 classes, and this is where I told you to remember sodium, potassium, and calcium. If you can remember sodium, potassium, and calcium, you've got 3 out of the 4 memorized right there, those blockers. Sodium, potassium, calcium, channel blockers. The other one is beta blockers. And this just gives you that information. What I want you to know is the 4 classes include sodium, potassium, calcium channel blockers, and also beta blockers. That's what I want you to know. Some other antiarrhythmic drugs include adenosine and cardiac glycoside. So let's talk about adenosine first. It is a potent vasodilator. It's a component of RNA. It's used for what's called PST, paroxysmal supraventricular tachycardia, PSVT. It's also used, interestingly enough, adenosine is also used for cardiac stress testing. You can see here side effects, and it's contraindicated in patients that have obstructive lung disease and asthma. Cardiac glycosides. These are all derived from the foxglove plant, known as digitalis. It increases the force of the cardiac contraction. So what I want you to know on this slide is adenosine is a potent vasodilator, and cardiac glycosides means digitalis, which has an increased force of cardiac contraction. There are some other drugs that are used as antiarrhythmics. These are all drugs that increase heart rate. So they're used to treat bradycardia, where the heart is going too slow. Atropine. This is a parasympathetic nerve system blocker. Isoproterenol. That's a non-selective beta agonist. Epinephrine is another. Their mechanism is all to increase heart rate and contractility. They do it all a little bit differently, but ultimately that's what they're doing, is increasing heart rate and contractility. None of these are given to patients who have cardiac ischemia. Remember we talked about ischemic heart disease, because atropine, isoproterenol, and epinephrine all worsen that ischemia. So let's do some quick quiz questions. What is ischemic heart disease caused by? What is congestive heart disease caused by? What are the 4 classes of drugs that treat arrhythmias? We talked about those. What are 2 other antiarrhythmic drugs? I give you adenosine and I ask you for the other. List 1 drug that out of the 3 that we just talked about that increases heart rate. What are some non-drug approaches to arrhythmias? And I want to ask you here really quick, which is done first? A drug approach to arrhythmia or a non-drug approach to arrhythmia? Make sure you keep that in mind as well. Okay, so moving on to, this would be chapter 14 in your book. This is now about drugs that affect blood. And in order to talk about drugs that affect blood, we need to start with the concept of hemostasis. Hemostasis, there's some type of vascular injury. And when a vascular injury of some sort occurs, you have vasoconstriction, platelet activation, coagulation cascade, and blood clot formation. Those 4 stages are what you need to know. Again, you have your vessel injury, you have your vascular spasm, you have formation of platelet plug, and you have coagulation, which includes fibrin filaments and that clot forming. And then this is just information about the coagulation cascade. You will sometimes hear about proteins that are involved in the coagulation process. You'll hear about different factors. And you'll also hear about how these proteins of the coagulation cascade, where they may be expressed or how they may be involved, and the factors that they impact. But only if you get heavily into talking about blood and that sort of thing. All right, so back to hemostasis. There are 4 action steps. They occur in this order: vasoconstriction, which is that spasm, platelet activation, coagulation cascade, and then blood clot formation. Make sure you know the 4 of those. You don't necessarily have to know them in order, although I think it would be a really good thing if you knew them in order. But you definitely need to know that these 4 occur. And I guess really the order would be helpful. Okay, so let's talk about antiplatelet agents. These decrease the formation of chemical signals that promote platelet aggregation. So the goal here is to prevent arterial thrombosis, especially during a heart attack. What are some types of antiplatelet agents? There's NSAIDs, P212 ADP receptor blockers, and 2B3A receptor antagonists. NSAIDs include aspirin, ibuprofen, naproxen. These are these reduce prostaglandins, and what prostaglandins do is they are enzymes that promote inflammation, pain, fever. So you can see how if you have enzymes that are promoting inflammation and you take a drug that reduces that enzyme, how that's going to be helpful. The P212 ADP receptor blockers prevent platelet activation. And the one that I need you to know is Plavix. That is the most common one used, Plavix. It prolongs bleeding time. There is another one, Persantine. I didn't bold it here, but just FYI, sort of a piece of trivia, it doesn't alter bleeding time, and it's also used in cardiac stress testing. Then you have 2B, 3A receptor antagonists. These interfere with platelet cross-linkings and thrombus formations, that clot formation. Integralin is the one you need to know. So if you know nothing else other than antiplatelet agents prevent arterial thrombosis, they include aspirin, ibuprofen, naproxen, Plavix, and Integralin. Anticoagulants. All right, now let's stop here and talk about anticoagulants. These inhibit the development and enlargement of venous arterial thrombi or clots. Okay, I'm going to say that again. These inhibit the development and enlargement of venous and arterial clots. Anticoagulants cannot dissolve clots already formed. Anticoagulants cannot dissolve clots already formed. Okay, that's what a thrombolytic does. A thrombolytic is the only one that can dissolve clots already formed. Anticoagulants simply stop the development of any new clots, and they stop the current clots from getting bigger. Make sure you know that. All right, so types of anticoagulants. All of these you need to know. I'm sorry, but I see them so often in medical records. Heparin and low molecular weight heparin include enoxaparin, which is Lovenox. There are vitamin K inhibitors. Those include warfarin and Coumadin. Now I'm going to stop here for a minute and tell you, an anticoagulant is a vitamin K inhibitor, right? Meaning that if you give a patient vitamin K, what does it do? It coagulates their blood. It thickens it. Okay? So if you have a patient who is on warfarin or Coumadin or any of these anticoagulants, and you suddenly need to get them ready for surgery, you have to take them off. And if their vitamin K level is low enough, you actually give them vitamin K and a vitamin K infusion to bring their level up so that they will clot better for surgery. So going back, anticoagulants include heparin and low molecular weight heparin, vitamin K inhibitors, thrombin inhibitors, direct factor XA inhibitors. Those are the different types of anticoagulants, but the specific ones you need to know are enoxaparin, which is Lovenox, warfarin, which is Coumadin, dabigatran, which is Pradaxa, apixaban, which is known as Eliquis, and rivaroxaban, which is Xarelto. The names that are in parentheses are brand names. The names that are before the name in parentheses are the generic names. So you may see warfarin, but the brand name for warfarin is Coumadin. So that gives you an idea. One of the things I think you should know is that there are a large number of drug interactions when it comes to oral anticoagulants. Thrombolytic drugs. What did we say about these? These are the only ones who can dissolve clots. Okay? Thrombolytic drugs dissolve clots that have already formed. They do that so that the tissue perfusion begins again, that oxygenation. And how do they do that? They activate the plasminogen that initiates the whole fibrinolysis process begins. Please know that the older the clot, the harder it is to break down. Again, hint, hint, hint. The older the clot, the harder it is to break it down. The two types of thrombolytic drugs that you will hear about most often are streptokinase and TPA. Streptokinase is bacterial in origin. TPA is human origin. Streptokinase has been known to cause allergic or anaphylactic reactions because of its bacterial origin. And some patients have developed antibodies to streptokinase, which means that when they receive it after TPA, it inactivates the streptokinase so that it doesn't work. Phosphodiesterase inhibitors, or PDEs. These inhibit platelet aggregation, cause vasodilation, increased contractility, and increased heart rate. There are two types of PDEs. One is PDE3, the other one is PDE5. PDE3 inhibitors are used most often with non-CHF patients. They are known to work very well for patients who have PAD, peripheral arterial disease. Patients with peripheral arterial disease often suffer from what's called intermittent claudication, which means they have ischemic leg pain. PDE5 is used with CHF patients, but it's also used for pulmonary hypertension and male erectile dysfunction. Quick quiz questions. What are the 4 steps of hemostasis? And I start you off with vasoconstriction and end you with blood clot formation. So what are the 2 in the middle? But make sure you know all 4. Which of the following is not an antiplatelet agent? And then name 3 anticoagulants. Give me 3. True or false, anticoagulants can dissolve already formed clots. True or false, the older the clot, the harder it is to break down. True or false, some PDE inhibitors cause vasodilation, so are not to be used long-term with CHF patients. Moving on to anemia. Anemia has 6 basic causes: iron deficiency, B12 deficiency, B9 deficiency, which is also known as folic acid or folate deficiency, decreased blood cell production, blood loss, which can be acute or chronic, or even acute on chronic, and then red blood cell destruction, or red blood cells that are not formed properly, like sickle cell anemia. That would be a type of red blood cell destruction. Symptoms of iron deficiency can vary from person to person, but here are a list of symptoms. And you see the list on the left. It includes fatigue, weakness, sluggishness, headache, irritability, difficulty exercising, shortness of breath, rapid heartbeat, pounding heartbeat, lightheadedness, dizziness, fainting, brittle nails, sore tongue or mouth ulcers, restless legs, and abnormal craving to eat non-food items like clay, dirt, or paper, and abnormal craving to eat ice. And then you have here on the other side, it shows the body and also shows some of the additional ones. There are foods that can help fight anemia. And it talks about how anemia is when the body's red blood cell count drops below a minimum level. It affects about 1/3 of the population across the world. Men are said to have anemia when their hemoglobin level drops below 13.5. Women are considered to have anemia when their hemoglobin level reaches less than 12. And so let's talk about really quick some foods that are high in iron, because iron deficiency anemia is one of the most common types of anemia. And this just lists for you a whole bunch of foods that are high in iron. So it includes beef or chicken liver, cooked beef or cooked chicken or cooked turkey, mussels, oysters, haddock, perch, salmon, and tuna, canned sardines that are in oil, lentils, lima or kidney beans, chickpeas or split peas, tofu, raw spinach or broccoli, dried apricots or peaches, raisins or prunes, almonds, pecans, walnuts, pistachios or cashews, pumpkin seeds, sesame seeds, sunflower seeds or squash seeds, wheat germ, or brown rice. Acute blood loss is usually the result of hemorrhage, often coming from trauma, surgery, or some type of vascular disruption. When that happens, the way that it's approached is to replace the blood volume, which would mean transfusion, identifying the source of hemorrhage, and stopping the blood loss. When it comes to chronic blood loss, because acute and chronic blood loss are another very, very common type of anemia, chronic blood loss, you look for your sources or symptoms. A lot of times it's very similar to iron deficiency anemia, but it can be caused by GI bleeding, hemorrhoids, or even menstrual blood loss in women who have fibroids. Diagnostic studies are used to identify the source and stop the bleeding, and a lot of times they will give supplemental iron to help with it. So that kind of leads us into what are the drugs, or vitamins in this case, that are used in the treatment of anemia. There's 4. Erythropoietin, which stimulates red blood cell production, iron, vitamin B9, which is folic acid or folate, vitamin B12. Those 4 treat anemia. Make sure you know them. Lipid-lowering drugs. This is another type of cardiovascular system drug we're going to talk about. In fact, it's the last one for today. So if you're thinking, oh my word, she's been rambling on forever, hopefully I'm close to getting done. Lipid-lowering drugs are used to treat elevated serum lipids, also known as hyperlipidemia. You may have seen that term, hyperlipidemia. The goal with lipid-lowering drugs are the next 3 items, and each type of drug does one of the 3. So there are lipid-lowering drugs that decrease the production of lipoproteins or cholesterol. There are lipid-lowering drugs that increase the degradation of lipoproteins, the breakdown, getting rid of those. And there are lipid-lowering drugs that increase removal of cholesterol from the body. Well, what are lipoproteins? I can hear you asking that in your mind. These are proteins that bind and transport fats. They include lipids and triglycerides that are in the blood. Have you ever heard of HDL and LDL? HDL is high density lipids. It's your good cholesterol. It's the one you want to have in your blood. LDL is low density lipids, and that is bad cholesterol. So make sure you know HDL is good, LDL is bad. So looking at the specific lipid-lowering drugs here. The first type are statins, and they include atorvastatin, which is Lipitor, pravastatin, which is Pravachol, rosuvastatin, which is Crestor, simvastatin, which is Zocor. I need you to know that. List the side effects for you in case you're interested. Ezetimibe is also known as Zetia, and this inhibits the absorption of cholesterol. Another type of lipid-lowering drug is bile acid binding resins. And I'm not going to make you know any of those, but please know these lipid-lowering drugs are statins. They inhibit the absorption of cholesterol. They're bile acid binding resins, or they're niacin, vitamin B3. And that increases HDL, lowers triglycerides. So anything in bold on this screen you really need to know. Hint, hint, hint. I brought this visual in because it shows you those 4 types: the statins, the ezetimibe, the bile acid resins, and the niacin. And it just tells you what each one does. I'm sorry, it's a little fuzzy. Quick quiz questions. What are the name 3 out of the many causes of anemia? And make sure you know all of the 6. Make sure that you know all of those that we're on. this. Make sure you know all 6 of those for your quiz. Hint, hint, hint. Okay, so what are 3 causes of anemia? What are 4 food items that can increase iron levels for iron deficiency anemia patients? Which anemia treatment drug stimulates red blood cell production? Make sure you know which one of those it is. True or false? Lipoproteins bind and transport fats such as lipids and triglycerides in the blood. Which is the good cholesterol? Is it HDL or LDL? Name 3 brand drug names of lipid-lowering drugs. And that would be off this slide here. 3 brand names. And the brand names are the ones that are in parentheses. I give you the generic name first, then the brand name in the parentheses. So make sure you know at least 3 of those, and I would prefer you to know all of the ones that are in bold. Please know all of the ones that are in bold for your quiz, your final quiz. Okay, that is it. I did not do slides that have review questions on them because, as I said at the beginning, I am using questions from the quick quiz questions in this slide, in this PowerPoint for the quiz. There are some additional ones, but the information is coming from bolded items. So you can do it. I know you can. It's only a 30-point quiz. You've got it. Have a wonderful week learning about cardiovascular drugs, and I will be back for week 6, where we will be moving on to central nervous system drugs, and that has to do with the brain and the spinal cord. All right, and primarily the brain, I believe, is what we're going to focus on, but some spinal cord too. All right, take care. Bye.